Hello there, Andrew Kolsky with Therapy BTS, behind the scenes, what really goes on in therapy and what's it really like to be a patient and a therapist these days. What's your therapist thinking? Today, we're talking with Erin Jones, and Erin is in North Carolina with Bull City Anxiety, and she does a lot of work with OCD as well as other things. Erin, welcome, and could you introduce yourself to the audience?
Thank you, Andrew. I'm excited to be here. Thanks for having me. My name is Erin Jones. I am a mental health counselor close to Durham, North Carolina. I'm a therapist and part of a OCD specialty group called Bull City Anxiety and OCD Treatment Center. I'm also a member of the International OCD Foundation and serve on the board of OCD North Carolina, and just really love working in this field and in this specialty group.
Fantastic. And I'm so happy to have you here talking with us today. OCD is sort of, one of my specialty focuses, and I love learning about it and talking about it. It is, a little bit of an offshoot from traditional therapy. And so I'm looking forward to a conversation about that. But before we dig into the OCD, tell us about Erin Jones. How did you get into the mental health field in the first place? And then kind of how did that get you into OCD?
Yeah, it depends how long we want to go there. It's kind of a journey of I'll give you the abridged version, but was definitely always interested in psychology in general, even when I was younger. And then I studied psychology in undergrad at NC State. Go Wolfpack, if anyone from North Carolina is listening. And then I, several years later, went back to grad school in the Asheville, North Carolina area. Was very generally interested in therapy. I had seen, I think a lot of therapists agree, you don't hear much about OCD and exposure and response prevention in undergrad and grad school unless maybe you go into an internship or something where that's happening a lot more. I did know that I liked CBT, was definitely leaning more towards the evidence-based practice, like doing things that work. And over time, really through supervision, really awesome mentorship, it kind of found me. People who supervised me in the past told me that they thought that it would be kind of a good niche for me. Maybe little did they know, like I could relate to it in a lot of ways personally as well. So that built into getting more supervised practice in OCD, also working with kids, a lot of the related stuff too, phobias, body focused repetitive behaviors like skin picking, hair pulling. So as I did more of that work, I felt like, yeah, this is my thing. Like these are my people, I can't, I don't have experience with all of these disorders necessarily personally, but I know what they do,
Mhm.
So that I'd say that just that love for the community really grew over time. Then getting involved in the International OCD Foundation, uh, that kind of sealed the deal, you know. Um, got 5 or so years of good counseling experience, again with great mentorship, and completed the BTTI training, the pediatric track through the International OCD Foundation, which is kind of a kind of gold standard, I think, OCD like certification program. And decided to make a life change this past year, and moved to a different part of the state to work with the specialty group that I'm at now.
Fantastic, fantastic. So your story is very, very similar to almost all OCD specialists that I speak to. And I'm really curious because you mentioned the fact that this is not something that they really teach in school. And I've yet to find anybody who has really told me they learned about it in school, with the exception of one person. And so, as you think back when you were working with patients before you actually started to learn about OCD treatment, Were there any cases that you think back now and say, you know what, that person probably had OCD and I just didn't realize it?
Uh, yeah, I think, and when I interned at practicum hours, I worked with a community mental health agency in Western North Carolina, and primarily just saw kids. And yeah, I think a lot of it was probably there, it kind of in the mix. I think a lot of us going to see this blending of generalized anxiety and OCD. Uh, I have seen it in my own life. I didn't even learn that I had a lot of symptoms of OCD combined with general anxiety until I was getting more experience as a therapist. It's like, oh my
Mhm.
gosh, those other things from my own past make a lot more sense now. So yes, in my life and in clients too.
Yeah, and that's, I can definitely talk about the cases that you know, people came in with things that was like couldn't really get my finger on it. But of course, nobody ever taught me about OCD. And then when I learned about OCD, it's like, oh, that's what that was. um,
Yeah.
so it's a really interesting area. That's kind of what got me started learning all about OCD as well. Um, you mentioned that you've done work with kids, and I know in our conversation previously, you shared with me you do some work with postpartum work and also with kids as relates to OCD. And those are, definitely some subcategories within a subcategory. And I'd love to hear more about your experience with that. So why don't you first tell us about kids? Like, what ages do you work with?
I, especially even moving more into the OCD specialty, I've done a lot of, I guess, kind of garden variety CBT work too. So it's really been ages 5 and up, anywhere from, very, very small kids to older adults in my office, people who have worked with me back when I was in an office rather than online, kind of, you could hear if it was my clients coming in because we're playing games and yeah, sometimes gets a little louder, but yeah, ages 5 and up for me.
Okay. So that raises an interesting question, especially with the younger kids. Obviously, I'm assuming the parents bring them in because something's going on, but they don't know exactly what's going on. Have you ever run into cases where you're trying to figure out, is this a child who's dealing with OCD, or is this a child who might be on the spectrum, or both, or how do I know? Have you ever dealt with those cases?
Yeah, it can certainly be hard to tell sometimes. I think, being in this, I suppose, specialty realm now, where we usually have a hunch that a child or an adult has OCD if they're coming in for those, concerns. With children, it can typically look like a lot more like confessing to your parents a lot that you had a bad thought, or maybe some more superstitious type behaviors, but not always. A child can have more, mental compulsions as well, or they may just start to have a lot of confusing repetitive behaviors around the house. Yeah, sometimes I've met kids too where we're not really sure if they may have an autism spectrum disorder diagnosis, and if that's the case, if we don't really know, then we might recommend more testing to see what
Mhm.
might be the best fit. But I've worked with a lot of kids on the spectrum too, doing like social skills and things like that.
Yeah, it reminds me of a case that I had that was, I really think it's a good case example if it were a school scenario. And the case was basically this. I was working with a child, let's see, I'm trying to remember how old he was. He was probably about, I don't know, let's say roughly 10 years old, male. And he had a younger brother who was about, I don't know, 5 or something. Maybe less than 5, probably 3. Yeah. Yeah. Anyways, he came in because he had these thoughts and things, and his thoughts dealt with inappropriately touching his younger brother. Now, he, obviously being an OCD thought, it's something that really caused him a lot of despair, because he didn't want to be doing this. He knew that he didn't want to be doing this, but this was the thoughts that was coming in. And so, you know, very, very standard OCD type of thoughts, obsessive thoughts. The challenge was, um, even though I knew OCD at the time and I worked with OCD, I belonged to these, you know, groups of therapists will get together just to kind of share cases and talk about things. And so, you know, a couple other therapists in the group, very good therapists. They just weren't OCD specialists. And I was getting a strong push to contact Child Protective Services because, you know, this kid was having thoughts about it. I said, it's OCD, that he's not doing anything. There's nothing wrong here. There's no inappropriate conduct happening.
Just a thought.
Yeah, it was just a thought, but but I can imagine, you know, other therapists who don't know OCD and a client comes in like that, them contacting CPS and getting the authorities involved. And I don't know whether the people at CPS know anything about OCD, and you can just imagine the turmoil that could occur. That case just came up, and it's like, you know, there's consequences about not understanding OCD because things like that can happen. So
Yeah, and to me, I think there's so much OCD out there. It's so common, and I don't believe that we really know the true extent to how common it really is because of, I think, obsessions like that where it's scary to tell
mhm,
people. I think it's so important if you're a therapist, maybe where you don't quite work with OCD, but you just curious. I think we're still doing our ethical duties to learn a little bit more to be able to know, okay, this may be something else besides, you know, true intent or danger, because it's not with OCD.
right, right. Well, and especially when the patient is saying, I don't want to be doing this. Well, that's kind of the opposite of intent. Um,
Right. You're fearful of your thoughts, and part of what makes it an intrusive thought with OCD is that it's different from your worldview. It's has nothing to do with, you know, it's quite the opposite of what you believe.
yeah, yeah. So, and then obviously that's one of the reasons that I do this podcast, is helping to educate
Yeah.
people, you know, what's it really like, what's really going on. Um, so when you're dealing with the younger population, I'll say your teens and below versus maybe your seasoned adults with OCD, do you find any particular differences, or is it all the same, or what's your experience been?
I mean, there are some differences. I think at the same time, a lot of things can be similar. For example, I feel inclined to say with children, we need to do a lot more education, but that's not necessarily true. A lot of adults need that education and normalization of their thoughts as well. But with kids, you know, it's probably a lot more interactive, maybe a little extra self-disclosure from me to to help normalize the thoughts. More of challenges and exposure therapy being like a game, or maybe, like, for example, with perfectionism, who can, let's do some drawing together and see who can
Yeah,
mess it up the best, and that sort of thing. Again, not that that necessarily couldn't happen with an adult, but you have to lean into that. With children, I think you also have to do a lot more family work, and that can certainly still be beneficial to adults too. If somebody lives with their parents or a partner, we want to try to bring them in to help support. With children, it's necessary.
yeah, yeah. No, that's definitely a big issue, is the making sure the family is on board with the treatment, you know, as well, because the desire to accommodate is understandable from a parent's perspective. You know, they want to make their kid feel comfortable and not stressed, but when they understand that that's not effective or helpful in therapy, then, you know, typically they can get on board. What
Yeah.
about, you know, for me, what I have found, you know, just personally from my own practice, when I'm dealing with like, let's say teens and below with OCD, I know some therapists I spoke to say that, you know, that's harder than working with adults for them. For me, I tend to find that it's easier. And the reason that I say that is because I guess since teens and below are, their whole life is going to school, basically, that they're used to listening to a teacher. So when you're doing that psychoeducation part and explaining what's going on and how it works and why it works, they're attentive, and they also tend to want to follow along because they want to learn, they want to be part of it. And so I found that treatment tends to be easier because they do their homework, they do what they're supposed to do, and they don't question it or challenge it as much. But maybe that's just me. Has that been your experience, or is yours different?
You mean because they're students and they're kind of used to that school format, that the therapy tends to go well in that like education, like student relationship type
Yeah,
way?
they
Yeah.
can follow along, and they're if they have homework, they realize, okay, I got to do my homework, and wait, I give them homework assignments.
Yeah, sure. Sometimes I think being used to school, even like teletherapy maybe, and used to the screens and things like that can be helpful. Kind of knowing, hey, we're gonna learn more. I think also with younger folks, there's kind of just that therapist style. Like some of us like to work with kids and teens, some of us want to stay away from it, and like that's okay. That's just not your, that's not your area. So yeah, I think part of it's just kind of a love for that age group, which I certainly have, and I think also like kids, teenagers, they want to learn about all this stuff just as much, if not more so than adults. They just want somebody to, one thing about school is unfortunately I don't think they're talking about this stuff that much. People aren't sitting there talking about all these intrusive thoughts, and we want to help educate younger folks and spread awareness so they know they're not alone.
Yeah, no, definitely, definitely. And that's just like you talk about, getting the family involved is just as important to get the teachers involved, because if you've got a teacher who's punishing a kid for doing a compulsion, that's not going to be really helpful. So,
Yeah, I mean, I think with kids, yeah, as they get a little older, you might have more sessions individually and privately, but really, I mean, I've been taught, and I think it's really a disservice to the child if you're not involving the family. That's their
yeah,
support, that's their household. Everybody needs to be on the team.
right, right, absolutely. So I know that, you said one of the other groups that you do some work with is the postpartum type of work. Tell us about that. First off, what is it? What does it mean? What does it look like? Give us the whole picture.
Yeah, yeah. I was anyone who knows me watching this will laugh if someone says, "Hey, do you have any thoughts on this?" Like, yeah, I have a lot. How much do you want to know? Um I so what is it? It's called perinatal OCD, but I people also refer to it as postpartum OCD, maternal OCD, really anything from honestly conception to like toddlerhood in terms of but we typically think about the pregnancy and postpartum period, the first several weeks up to a year after birth. And although this can of course impact any parent, yes, it tends to be a lot more likely for it to impact a maternal, a parent who's given birth, because of the added effect of hormones, and everything that comes with pregnancy and childbirth for a mother. What is it? It's still really the same symptoms of OCD, just the onset being during pregnancy or the postpartum period. What can make it, I suppose, a little different is because of everything that happens during that time. There can be just added stress of welcoming a baby to the family, everything that comes along in pregnancy, having a new baby in your life, not sleeping, already being genetically predisposed to OCD. Uh, it's just another area that I have another love and soft spot for, not only in terms of advocacy, but because I'm also a mom and have two kids. And, what really makes me think of it was earlier when you were mentioning your child client who, where maybe another therapist might have unfortunately thought to call CPS. A lot of new moms feel afraid to share about their intrusive thoughts in those doctor's appointments after having the baby, because they're worried that they'll get in trouble. Somebody will think that they're going to hurt their baby and try to take the baby away when that's not what's happening. Somebody can have intrusive thoughts that they're worried something bad is going to happen to their baby. So I know that kind of answers your question on a broad scope, but that's a little bit about what it is. And I think why it's really important for there to be more awareness to how OCD can come up in this phase of life.
So just to clarify for the audience, so you've got a situation where you've got a new mother maybe, and the thoughts are, I'm going to do something to harm my child. Could be a typical OCD, harm OCD type of thought. So maybe, I don't want to be the one to bathe the child because I'm afraid I might drown them or something, even though they would never do that. They have that thought. So raising that thought to a physician or somebody who is not trained in OCD, that can be scary for the physician who, has reporting requirements and things. So it can become a really, challenging area for a lot of people. The one thing that I've run into, interestingly enough, and I'm curious whether you have, is the number of new moms, specifically new moms, young kids, and my patient ends up being the family or the husband or, someone associated with the mom, because the mom has OCD, but either poor insight or no insight. And they believe they're absolutely right. And they do things that are just so textbook OCD, but they're not aware, and it causes a lot of strife in the family. Have you ever dealt with any of those?
Yeah, I think it's tough if there are cases like you're explaining where there's low insight, meaning, the person believes that their thoughts or worry is really are, they don't want to take their chances. So if, for example, a new mom is worried, oh, what if I drop the baby? What if I hurt them in some way? That is scary. But OCD adds this really heightened personal responsibility. So okay, now I care so much about the safety of my baby. So that must mean that I should be the only one that can hold them at all times. And I need to be really careful, and I need to research things, and I need to watch the monitor at all times. Now this mom's further in the OCD cycle, and they believe that they need to do those things to keep their baby safe, or to stay clean or be right, or it could really still take any OCD theme, but it tends to be more focused on the baby. It's certainly tough in those situations, especially if there's a new parent. I think if you're meeting with a partner, and then the maternal parent, has low insight, the partner can get a lot of support in education. I think that there can be ways to help involve some of the medical professionals, whether it's like a midwife or the OB provider, uh, to help check in medically on the new parent too. Thinking about ways to give that parent more support in general to hopefully contribute to gaining more insight there.
Yeah, and that's, you know, it, it, I'm thinking of two cases in particular that I've had where um, it was very, very difficult to get any to get through. When there was poor insight or no insight in certain cases, logic doesn't matter, facts don't matter, reality doesn't matter. It's whatever their OCD thought is that matters to them. And you try so hard to approach it obviously from a compassionate, angle, and very, soft, allowing them to, as you would in any therapy, allowing them to come to the conclusions, allowing them to kind of work through the problem in their own head and figure out how things work. And in one case I'm thinking of, it was just sort of like it didn't matter, because if their own logic came to a certain conclusion, but that conclusion was different from their OCD thought, they would immediately dismiss it and find some way to dismiss it, even if it sounded completely illogical and
Yeah.
contrary to the facts. They would dismiss it anyway, because they were so bought into the obsessive thought.
And I think it can be, it's why it's a really scary time. I mean, you add in the factor of the client being, you know, somebody who gave birth to a child or is pregnant with a child. Again, I feel like it really pings on that personal responsibility, right? Like I'm the mom, or I'm the birthing parent, so I need to do everything I can to prevent this scary thing from happening, or to keep my baby clean, to prevent them from getting sick, whatever the, you know, core fear is in that circumstance. And I that's why I hope that we will universally screen for this and be able to give new moms new support in general, even apart from OCD, where, you know, if people start to experience more of this, they can know, okay, there's something going on here beyond maybe a just like a normal protection for my child, you know.
Mm-hmm. Yeah, and that's that's one of the challenges, I think, for therapists, because you can imagine, and I'm sure you've seen it, where you've got a mom who has a new baby, who has ARM OCD, let's say, and they're getting into a lot of conflict with their partner, with their family, who's saying you're being too overprotective, these types of things. And eventually they work their way to a therapist. And if they get to a therapist who's not trained in OCD, and therapist says, here's a new mom coming in, you know, afraid that her child might be harmed and trying to protect her child. Well, of course, that's exactly what we would expect. And maybe even encourage it when it's,
Yeah.
truly OCD. And what advice, if any, do you have for therapists who are not trained in OCD who might be getting those types of clients?
If you're a therapist not treating OCD and you suspect that you have a client, I mean, really anyone, but yes, focusing on these postpartum moms who likely have OCD, please refer to an OCD specialist. It's so important and vital, and part of your ethical duty to your clients that they receive that specialized treatment. And this can, you know, there's directories through the International OCD Foundation. There's postpartum.net, you know, but Postpartum Support International. So those are good places to start if you're not really sure where your client can get the best support.
Mm-hmm. Yeah, and I'll throw out a couple things here, and I'm curious if you have any to add. I'm thinking to myself, okay, so if I'm a therapist and I'm not trained in OCD, how am I gonna notice this? And so I'll throw out, well, you know, if you've
Mm,
got a new mom who's coming in, let's say in this particular case, very concerned about their child's safety, and to the point that their actions are causing a lot of turmoil with their partner, with their family, about being excessive, even though the mom feels it's not excessive. Maybe you see the mom doing a lot of research online, to find whether this or that could be harmful. And the things they're saying just sound a little bit beyond what logic and facts would tell you is correct. Yet
right.
they have a hard time following the facts or the logic because, well, but it could be and it might happen. Those are signs. I love that. This is Zoom does this thing. Whenever you do the air quotes, you get balloons and things, and that's amazing to me. So welcome to AI.
Yeah.
But anyways, those are some types of signs that may clue you in that there might be something going on here. What about you, Erin? Any additional things you can add?
Those are all really great clues where maybe, yeah, family members are reporting concern. Like, yeah, this person's worried, especially about their child and things around the home, but it seems excessive. One thing is that there are some screeners. There's a test called the Y box. There's if a good place I think for therapists to start would be to look at the International OCD Foundation's IOCDF.org has a perinatal OCD whole separate web page, and it summarizes a lot of common symptoms for OCD in general, but also especially perinatal and postpartum OCD. So I say all of that to say that if you do some reading on there, you'd at least be able to spot, oh, okay, these are some common obsessions and compulsions that at least tend to happen more when somebody is experiencing postpartum OCD. Are they, we want to screen to ask about certain behaviors, how much time are they spending thinking about danger to the baby and or checking, researching, did you look something up on your phone to just get a little bit of information on how the baby sleeps, or are you spending hours of your day checking, asking for reassurance, doing things repeatedly? Does
Mhm.
it is it done in an attempt to get rid of a fear or try to get rid of a fear or intrusive thought, or is it something that you're doing just to, again, just to eh, check because the baby seems sick and you want to check their temperature, you
Right.
know? So I think using resources like that can also be really helpful because it can give you a few ideas of things to be on the lookout for.
Yeah, yeah, and you make a very good point there about so it's the International OCD Foundation, which you've shared IOCDF.org, and they've
Mhm.
got a wonderful website with just enormous amounts of resources for all different types of OCD and even related disorders.
Yeah.
So, if you're a therapist or a patient and you're looking for information, that's a great place to start.
Yeah, they also offer uh, occasionally, I believe, a series of consultation groups, or you can reach out to, OCD practices in your area to learn more, consult. I agree with you, Andrew. I think it's really important. I would argue for all therapists, even if you don't work with it, to at least know some of the indicators that somebody could be experiencing OCD.
Yeah, yeah. Personally, I work towards the goal of one day getting at least some basic education about OCD into all, master's programs for counseling, because it's just not there right now. But at least giving people a fighting chance to recognize that maybe this is something I should look at further or refer to a specialist or whatever it may be. Um, Also, just for the sake of potential patients, on the IOCDF web page, not only can you find a listing or directory of people who are trained
Mhm.
to treat OCD, but there's a lot of support groups and resources available, many of them free. And some of them focus on particular areas, some of them are more broad. But
Yeah.
there's a whole listing there, and you can just peruse at your own leisure. But the resources are really, really good.
I agree. And postpartum.net through PSI does have some groups for new moms, dads, all gendered parents. So there's some great resources there too, specifically for that
Hmm.
area.
Fantastic. So can you tell us a little bit about, you said in the beginning that you also treat body focused repetitive behaviors and some similar things. What For someone who doesn't know, what is a body focused repetitive behavior? Why do OCD people deal with that stuff too? Give us some background.
Yeah, so many acronyms in this work, but uh, BFRB is body focused repetitive behaviors. Are there's a wide variety of them. I would say the most common that people experience or have heard of have to do with picking at your skin or pulling your hair, either excoriation or trichotillomania, and it's considered similar to OCD because although there's not necessarily an obsession or compulsion in that type of behavior, it kind of follows a similar cycle, right? So if somebody starts to, oh my gosh, for me in the past, so I've been picking at my fingers and my cuticles. I start to do it, and the behavior, although maybe not necessarily in a great way, starts to have some sort of function to it, whether it's a sensory thing or I'm able to even out some sort of blemish on my skin. I start picking at it, and then my brain learns that, okay, anytime that I have this urge or this sensation again, I have to do the same behavior repetitively until it feels right. So, although it's perhaps more of a habit, it can certainly feel automatic and uncontrollable and kind of takes that similar, it has a similar feel
Mhm.
to
Mhm.
OCD.
And so if somebody kind of resonates with what you're saying and they realize that they are doing that, is there treatment available?
For sure. It's not necessarily the same as ERP exposure therapy for OCD, but it's very close. I mean, it's if you've done exposure therapy before, you know that you're going to get uncomfortable, you're going to be waiting out that wave of anxiety, and it's similar with BFRBs. The most common approaches are called habit reversal training and the comprehensive behavioral model.
Mhm.
It's they're CBT based approaches. So if you're looking for somebody who treats this, it's good to look for somebody who's done habit reversal training or this comprehensive behavioral model. And we go into it really just like studying the behavior a lot. So we're tracking it, we're looking at when does it happen, what type of environment does it happen in, um, are there any precursors to it? Are there certain, the comprehensive behavioral model also looks at like, are there certain functions to the behavior? Again, is it a sensory thing? Is it to let out anxious energy? Like whatever it is. And then that helps us form alternate responses,
Mhm.
things to have around. So kind of like OCD, I think people just get told like, "Oh, just stop doing it," and easier said. Great, thanks for the
I never
advice.
thought of that.
So this really like breaks it down into better understanding the behavior, being able to anticipate it, and learning skills to shift it slash be able to wait out that really uncomfortable urge to do it. And it's really cool. A lot of people can really see a big difference there.
Yeah, yeah. So it's as we start to wind down here, let me ask,
Mhm.
because as you're talking about the BFRBs, do you also treat tic disorder?
I have some. I don't have a lot of because I have a strong CBT history. I haven't treated a lot of really severe Tourette's cases, but it's yes, habit reversal training. I have worked with some folks who have tics, and it's used very similarly.
Yeah, that's why I asked, because it's
Yeah.
basically, a very similar approach. And for again, just for those listening, the jargon here, tic disorder. So some people will have motor tics, like maybe you'll see somebody, scrunching their eyes or something like that, or they'll have vocal tics. They might go, huh, huh, things that
Mhm.
you're like, oh, just stop doing that. Well, they can't.
Right.
It's not as simple.
That's why it's
So
still happening. Yeah.
right. I mean, that's you think they want to just walk out into a public place and go, "Hmm." They don't want to be doing that. But anyways, there are effective treatments for that as well, which is follows along with the habit reversal training. So all of these things that we've talked about today fall into a similar bucket in a way. And you tend to see it. You may see like combinations, like I've had people with OCD and tics.
Yeah.
You'll see a lot of similar things. So,
Mhm.
so let me ask this. So obviously you are very well versed in this OCD treatment and similar treatment, and it's important that people find people who are knowledgeable if they're trying to get help. How would somebody find you if they wanted to get in touch with you?
If somebody was looking for me, they can find me through our website, bullcityanxiety.com. To look for me specifically, I have a professional Instagram. I just changed it to, I think Erin Talks OCD. but just to look for therapists in general like me who are trained in this specialty. As you mentioned, that IOCDF directory is a really great place to start.
Mhm.
Or if you're looking for therapists like myself, maybe on Psychology Today or something, it's good to have a couple of questions to ask specifically if this therapist has a lot of training in OCD. Do they tend to see a lot of OCD or related diagnoses on their caseload? Um, and if they practice ERP or
Yeah.
habit reversal training for the others. But yes, you can find me through bullcityanxiety.com.
Great. Yeah. And you make a really good point there, which is if you're seeking a therapist and you know that you're looking for someone to help with OCD or whatever you're seeking a therapist for, don't be afraid to ask the questions. How much training do they have? How much experience do they have? Can they share information about this? Any therapist who is appropriately treating any area can answer those questions easily. The one thing to be aware of is oftentimes, I'll speak with people who found someone who said they treat pretty much anything and everything. And so
Yeah.
that some of those people don't have any specialty. They may be very good in certain areas, but if they don't have specific training in things like OCD or others, it's not that they're bad, it's that they don't have the training. And if you don't have
Mhm.
the training, you're not going to be able to do effective treatment.
Especially for OCD, right? It's anyone listening who has OCD knows that it's very unique, and the treatment feels kind of counterintuitive to how we're taught to do things. And it's really important to meet with somebody who's either heavily supervised in OCD practice, meaning they have someone working with them in their training, or they have this specialty experience already.
Agreed. Agreed.
Yeah.
Well, Erin, thank you so much for spending part of your day with us and educating us more about what goes on. It's always interesting to hear from a therapist, like, what are you really thinking? What's really happening? What are you looking for? And this is it. So if
Think about a
you,
lot of things. Yeah.
yeah, yeah. But if you're someone in North Carolina who needs some help, I encourage you to give Erin a call or reach out to her. And she's certainly quite capable of being able to help you, and we're glad to have her as part of the community. Um, any parting words, Erin?
If anybody relates to the things we're talking about, or any therapists want to learn more, just please know you're not alone, and there are people out here who can relate, and we want to be here to help you. And thanks for
Fantastic.
having me.
All right. Well, thank you for your time. We really appreciate it.
Thank you.